Hi friends, today I will talk about the character of the pulse. First is the disclaimer. Caring Dogs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. And information available is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. Character of the pulse, it refers to the shape of expansion and contraction pressure. A regular character indicates that pulse is consistent in shape and duration, and it shows the strength and volume of the pulse. Usually we measure the character of the pulse in the carotids. When we assess the character of the pulse as palpation should show a smooth and rapid upstroke and a more gradual downstroke with each pulse. Since it is best assessed in carotids, there are few exceptions, like collapsing pulse, which is better appreciated at radial artery, and pulsus bisferiens, which is best appreciated in the brachial artery. Character of the pulse is assessed by trisection method. Here, varying degree of pressures are applied with the finger pads of the thumb or first two fingers to assess the upstroke, systolic peak, and diastolic slope of the pulse. The component of the pulse wave are percussion wave, tidal wave, dicrotic notch or incisura. Percussion wave, it is due to the arrival of the impulse which is generated by the LV ejection. Tidal wave, it is due to the reflected waves from the upper part of the body, and dicrotic wave, it is the reflected wave from the lower part of the body. Dicrotic notch or incisura, this corresponds to the closure of the aortic and pulmonary valve, that is S2 sound. So in this diagram we see that uh, the forward wave or percussion wave, then we have reflected wave or tidal wave, then we have systolic pressure, augmentin pressure, we have a small notch, that is a dicrotic notch. This is how wave character of the wave pulse is assessed. These are the various waveforms showing different components of pulse, that is P, A and T and D. These are all between S1 and S2. So speed of the pulse wave and the time taken to reach the peripheral artery. Speed of the pulse wave is 5 meter per second, and the speed of blood flow is 0.5 meter per second. And speed of the pulse wave and time taken to reach the peripheral arteries like brachial artery, for carotid artery it is 30 milliseconds, for brachial artery it is 60 milliseconds, for femoral artery it is 75 milliseconds, and for radial artery it is 80 milliseconds. That is the uh, time taken by the pulse to reach from the heart or aorta to the carotid, brachial, and femoral and radial arteries. So it is least in carotid arteries. Normally, the radial pulse is felt 5 to 10 milliseconds later than the femoral pulse. If they are heard simultaneously, then we can say there is radio-radial and radio-femoral delay. There is radio-femoral delay. In the character of the pulse, different waves, we can have different character of the pulse in different cardiac pathologies. The catacrotic pulse is, it is the normal character of the pulse, where we see all the components of the wave. Pulsus parvus at tardus, it is a low amplitude pulse, that is parvus, with a slow rising and late peak, that is tardus. It is seen in severe aortic stenosis. Pulsus anacroticus is single peak low volume. It is also seen in severe aortic stenosis. Spike and dome shaped pulse is seen in hypertrophic obstructive cardiomyopathy. Water hammer pulse, also called high volume pulse or collapsing pulse or Watson's pulse or pulsal sealer. It is a high volume pulse. There is a sharp rise, that is systolic pressure is high, and ill sustained sharp fall, that is when the diastolic pressure is low. The pulse pressure is at least 60 mm of mercury. It is seen in severe aortic regurgitation, patent ductus arteriosus, arteriopulmonary window, rupture of the sinus of Valsalva, arteriovenous fistula, and severe mitral regurgitation. Pulsus bisferiens, it has two peaks in the systole, which is seen in severe aortic regurgitation, moderate aortic regurgitation and aortic stenosis, hypertrophic obstructive cardiomyopathy. Pulsus dichroticus is one peak in systole and other peak in diastole. It is seen when pulse rate and diastolic pressures are low. Dichrotic pulse is seen in typhoid fever, severe left ventricular failure, dehydration, dilated cardiomyopathy, endotoxic shock. And the pulse with alternating volume, we call them as a pulsus alternans and pulsus bigeminus. Pulsus alternans means alternating high volume and low volume pulses, but the rhythm is regular and the cough sounds double on lowering the cuff. It is seen in left ventricular failure. Pulsus bigeminus is pulse wave with normal beat followed by a premature beat and a corresponding pause. It occurs in rapid succession, resulting in the alteration of the strength of the pulse. It is very common in digoxin toxicity. Then we have pulsus paradoxus. When a systolic, we have it is seen that systolic blood pressure falls more than 10 mm of mercury during the inspiration. That is the it is normally seen that with normal inspiration there is at least about 10 mm fall of blood pressure. When it is exaggerated, that is systolic blood pressure falls more than 10 mm of mercury during inspiration, then we call it as a pulsus paradoxus. It is seen in constrictive pericarditis, severe asthma, chronic obstructive pulmonary disease, cardiac tamponade, tension pneumothorax, massive pulmonary embolism, and other anaphylactic shock and obesity. Reverse pulsus paradoxicus is in inspiration. There is inspiratory rise in pulse volume and pressure. Usually, there is inspiratory rise in systolic blood pressure, but in reverse pulsus paradoxus, there is inspiratory rise in pulse volume and pressure. It is seen in intermittent positive pressure ventilation in the presence of left ventricular failure, hypertrophic obstructive cardiomyopathy, and isorhythmic AV dissociation. Absence pulsus paradoxicus in constrictive pericarditis. It is associated with large atrial septal defect, ventricular septal defect, and aortic regurgitation. How do we elicit the pulsus paradoxus? As we know that pulsus paradoxus refers to the exaggerated fall in patient's blood pressure during inspiration by greater than 10 mm mercury. Patient is placed in semi-recumbent position. The respiration should be normal. Do not instruct them to change their breathing pattern, as the depth of the inspiration influences the magnitude of the pulsus paradoxus and will be amplified in patients with pulmonary diseases. The blood pressure cuff is inflated at least 20 mm of mercury above the systolic pressure and then slowly deflated until the first cough sounds are heard. The initial sounds will be heard only during inspiration. We have to note the level. As the cuff is further deflated, the first cough sound will be heard during the both inspiration and expiration. Note this level. If the difference between the two is more than 10 mm of mercury, then it is the pulsus paradoxus. This is not a true paradox, as it is an exaggeration of the normal phenomena of the fall of blood pressure during the inspiration. What is paradox? Paradox is that in patients with constrictive pericarditis, during the inspiration, the blood pressure might drop significantly enough that the peripheral pulses will be absent. However, the heart sound still can be heard. How do we assess the pulses alternance? Pulses alternance refers to alternating high and low volume pulses. Patient is placed in semi-recumbent position. Pulse alternance is diagnosed by first palpating the radial or femoral artery, feeling of regular rhythm but alternating strong and weak pulses. Then the blood pressure cuff is inflated at least 20 mm above the systolic blood pressure and it is slowly deflated until the first cough sounds are heard. Initially, the cough sounds are due to high volume pulses. On lowering the blood pressure, the cough sound will be heard due to both high volume and low volume pulses. This will produce a doubling of the cough sounds best heard in the left ventricular failure. Collapsing pulse is characterized by the rapid upstroke followed by a rapid descent of the pulse wave without a dichrotic notch, which reflects low systemic pressure resistance. So, low systemic vascular resistance. A rapid upstroke is due to rapid ejection of greatly increased stroke volume. The rapid descent or collapsing character is due to a diastolic runoff, that is backflow into the left ventricle, reflex vasodilatation mediated by carotid baroreceptor secondary to large stroke volume, the rapid runoff of the peripheral due to decreased systemic vascular resistance. Corrigan pulse or sign is largely due to Corrigan pulse or sign is due to largely abrupt distension and quick collapse of the carotid pulse in aortic regurgitation, whereas the term Watson water hammer pulse is used for characteristic pulse seen in peripheral arteries like radial artery. It is best heard in severe aortic regurgitation, patent ductus arteriosus, aortopulmonary window, rupture of sinus valsalva, arteriovenous fistula, and severe mitral regurgitation. How do we assess the collapsing pulse? We have to palpate the radial artery and trace the artery proximal to the point where it is just fell. At this point, wrap your wrist around the patient's forearm so as to place the head of the metacarpal over the artery. Simultaneously, palpate the radial and ulnar artery by encircling the patient's wrist with your other hand. Now, abruptly raise the patient's hand above the shoulder. In this case, artery becomes in line with the central aorta and allowing direct systolic ejection and diastolic backflow. In collapsing pulse, both radial and ulnar arteries are felt distinctly, and there is an abrupt thrust or knock and the collapse under the metacarpal head on elevation. Thrust produced is similar to the one produced by tilting of the water hammer toy. It is due to diastolic runoff in aortic regurgitation. How do we assess the pulse's bisferience? It is best felt in brachial and carotid arteries, felt by applying graded pressure with the fingers. Press and occlude the brachial artery, and on slowly releasing the pressure, the double peaking of the pulse is appreciated. Best heard in severe aortic regurgitation, moderate aortic regurgitation, and aortic stenosis, hypertrophic obstructive cardiomyopathy. Helen B. Tyson has said, "Learn to listen with your fingers." With this, I conclude my today's topic. Keep learning. Thank you very much.